Hi, everybody. Hope you can hear me okay. Um, so what we're going to do is we're just going to do a case study. It's quite an interesting one now as we're starting to get towards the warmer months again in South Africa. Some of you may be exiting the warm months depending on where you are. But anyway, I hope it's something that we can learn and something that we can use going forward. So um, a case study of a patient that we had in our unit. I just come across the file a little while ago and decided to keep it for a bit of the warmer time. So, yeah, let's have a look and see. So, this is the history on the patient. We had a 27-year-old male patient who collapsed at work while digging a trench. Now, even before you get on to the rest of it, you've already got to start working up your differentials here, right? So, a patient who collapses at work, number one, acute syncope. So, is this a central nervous system problem? Is this a cardiac problem? Is this a what you call it? Problem with the well, I suppose cardiovascular, cardiorespiratory, all of that goes in together. Then your CNS, you've got to think about what could it be. Are we talking about an acute injury, an acute CVA? What could we be talking about? But generally you'd be looking at those two big systems, right? So even before you went to see the patient, your plan of action would already be a neurological exam, cardiorespiratory exam. Of course, you'd look at the vitals, you'd want an ECG. Those are the things that you've got to start thinking about. It's very difficult without more history to know, but we assume there's no trauma involved because he just collapsed at work. Was digging a trench, so he was doing a lot of exertion. So you've got to start thinking along those lines. So this patient had no prodromal illness or trauma, 27-year-old, obviously somebody who does manual labor, most likely somebody who's actually quite fit and who can do quite a bit. So in this case, the patient was extremely pyrexia. So that's a big clue. So, would you be thinking of infection at this point? What would be going on? I think I've already given you a clue in talking about the warmer months. So, but in any case, let's go through it and see. Okay. So his vitals shown signs of acute shock that seems to be hypovolemic in nature. Why do we say that? We've got a young man, again, not known with any cardiac illness, possible sepsis, we don't know for sure. He's got a low BP of 80/63, heart rate of 137, respiratory rate of 22. It's quite high, blood glucose level of 3.7, and the GCS is showing us 9/15. Now, generally, pyrexia and infection doesn't cause you to collapse, unless you have an acute septic embolus or something like that. So you've got to start thinking, is there something going on over there? Is this related to infection, not an infection? That's what you've got to think about. And then you've got the co-worker also brought in with dizziness and pyrexia. Okay, so you've got two people presenting with similar symptoms. So what that makes you think is that whatever's causing this is not really related to the patient specifically, but there's an external factor. All right. So what externally in the environment could cause this? Now you've got to start thinking. Now we know the patient is pyrexia. Both patients are pyrexia. So this could be environmental factor, heat. It could be environmental exposure, toxins, poisons, gases, things like that. But considering these guys were just digging a trench, they weren't working in, a manufacturing industry, or they weren't isolated to some, some lab or technical section or something like that. We can assume that these patients are actually have been exposed, because you remember you're digging a trench. It's very rare to dig a trench inside. You're actually digging a trench outside. So these patients have been exposed to extreme heat. Right, so extreme heat, and especially those of you who come from the subcontinent, India, Southeast Asia, those of you who worked in the Middle East, and maybe towards equatorial countries, this might sound quite familiar. Patients who present like this, especially if you've worked in those areas, this will actually seem quite common. All right. Now, here in South Africa, or even those of you in Australia too, who have worked in Australia, this may sound quite familiar. This is what we would call a heat stroke. All right. Now, the question is, how do you manage these and how do you go along? Even though I've given you the answer, I was hoping your mind would be going towards that already. Now, in South Africa, depending on where you are, you tend to get exposure to this as well. So if you tend to come more towards the coastal areas, such as KwaZulu-Natal, Durban, well, Cape Town itself doesn't get that busy. In our area, it's more the northwest and northern province, places like Uppington, Kimberley, and then as you get towards Durban and Richards Bay and that coastal side, even going down south on the coast, we get extremely high temperatures during summer. So these are areas where you can expect to see these things happening. And even in Newcastle, where we are, there is a possibility that we can get it. We know we've had days of 50, 49. So we have had some seriously hot days over the last few years. And anyway, that's a discussion for another day. But anyway, so what happened when this patient was brought in? He was given stat antibiotics. So the doctor had seen him, so pyrexia, assumed infection, went with septic shock as a possible cause, and started giving him fluids. So the patient continued to deteriorate. Okay. So when the patient continued to deteriorate, they said, okay, this may be an intracranial abscess, there may be something else that's going on, without really considering the other patient as well. So this was more a case of, I think, panic on the part of the doctor who was working in the emergency department at that point, because this is not common presentation. So you go with what you know. And that's what he was thinking about. So in fact, this patient was moved on to the medical department, and they moved the patient to ICU also without making the diagnosis. It just didn't come through immediately. They sent the patient for the CT scan, and the urine district showed 4+ protein, which was the only thing that wasn't mentioned here. But we're getting to why it showed protein. So just to get into this, so the doctor who came to see the patient from the medical department was also a relatively young doctor, also only 2 or 3 years of practice. So not that experienced, not inexperienced either, but not that experienced either. And this brings into context something that we talk about in medicine, and specifically in ethics, which is bias. So we all have a bias. Now what happens is sometimes you create something called peer-to-peer bias. So what happens is a patient is brought in, you as the emergency room doctor make a diagnosis. Now you've got a hypothesis, and your patient kind of fits into that hypothesis. You're not necessarily right, but your patient kind of fits into it. So now you call somebody from another department, or what you feel is the relevant department, and they come, and you basically start giving them facts that are related to your hypothesis. So you create a bias in them. You are telling them your side of the story, if I can put it that way. You're not letting them examine the patient on their own. You're not letting them have a look and make up their own mind. You kind of tell them, well, A, B, C, D, E tells me it's this, which is something we all do. That's not a problem. But you've got to leave room for the other person to make their own decisions. So normally the best way to present a patient, now there's just a bit of ethics coming into it as well. The best way to present a patient is to give the facts and say, listen, this is what the patient has. Now, to my mind, this is what I'm thinking, but I can't say for sure that I'm 100% correct, because the patient is continuing to deteriorate. So by introducing that factor that I may be wrong, it sort of diminishes that bias in the patient, in the doctor's mind. So you create that opportunity for the doctor to go in and say, okay, maybe this person isn't correct in their thinking, and let's see what I can come up with. And you'll be amazed. People, not all of us know everything. So the person that you're calling may have experience in other areas of medicine, may know more about a particular topic, may have done a presentation on such a topic, you never know, and somehow has a different piece of insight compared to what you may be able to give. So never forget that that's always a possibility. Okay, so in any case, the doctor who came from medicine also, I suppose, maybe peer-to-peer bias, and said, okay, no, this is a severe infection. Let's get the patient to ICU, and continued with antibiotics and continued with fluids, and the patient was not doing too well. And actually, they ended up calling the consultant, their consultant in medicine. Their consultant in medicine then contacted me to know why I wasn't contacted. So I got a good scolding that day as well. So I wasn't contacted on such a patient, which I couldn't answer. I mean, I don't phone those of you who work in casualty, in the emergency department, casualty, whatever you want to call it. I don't phone you all and find out if there's patient. I normally depend on you all. But anyway, that was a bit of fun for me to talk to him about. But anyway, that's it. So this patient had what we call an exertional heat stroke. Now there's two types, right? So you get exertional, non-exertional. And we tend to think of heat stroke as only being associated with extreme temperatures, in other words, related to the weather. However, these can also occur in other situations. For example, yeah, just to give you a simple example that you can always put your mind to, a kitchen environment, let's say a restaurant, extremely hot, extremely busy. People are running around. There's lots of things happening. And you add to that maybe environmental factors such as a hot day, and you can easily get an exertional heat stroke. Non-exertional heat stroke tends to occur more in elderly patients, also related more to weather or circumstance. So, for example, you may have an elderly man sitting in a sauna, for example, not necessarily on a hot day, and they can easily present with non-exertional heat stroke. All right. So there's a few differentiating factors. So you have heat cramps, all right? So it generally happens at lower temperatures, and lower humidity is also an extremely important factor. The reason being, when we sweat, and when that sweat is actually brushed off your skin, that's what allows you to cool. Now, in extremely humid environments, there's nowhere for that sweat to go. So it remains on your body and doesn't allow your natural cooling mechanisms to work. Okay. So, heat cramps generally are the lower end of the spectrum. So you get muscle pain, tightness, severe sweating, all right? Heat exhaustion, normal or slightly higher body temperature, profuse sweating, dizziness, fainting, weakness, headache, nausea, and vomiting as we start getting more and more into it. And then heat stroke, very high internal body temperature, is what you saw in outpatient. Profuse sweating or dry skin. I remember in outpatient it was more dry skin, confusion, slurred speech, agitation. In other words, change in the mental status, and eventually what you call it, heart dysfunction, which is what presented to in our patient as signs of hypovolemic shock. In his case, he also had pulmonary edema, which was the reason why he was breathing so fast. Okay, then you get DICs, right? Now, once you get a DIC, I mean, your patient's just going to start bleeding from everywhere. Liver failure takes a bit longer, as does renal failure, and the renal failure generally is associated more with the heart dysfunction and rhabdomyolysis. So, rhabdomyolysis is one of those things that occur with heat stroke, and that's the reason for 4 plus protein. You've got all of this muscle breaking down that's now being excreted via the kidneys and eventually causes acute renal injury as well. Now, in my early days, when I first started off, it's a patient that I remember up till now, and I always remember and I regret, before I actually learned about all of these things, And I was a younger doctor, let's put it that way, and I received a call from a peripheral hospital, and doctors telling me there that it was actually during police training, during winter, surprisingly, but a warm day in winter, and a gentleman from there who was doing police training had collapsed, was complaining of symptoms of heat exhaustion, actually. If I remember, if I had to compare it to this, he was still awake, he was still talking, he was doing all of that. And his creatinine kinase came back as over 4,000. And I was like, but your ECG is normal and this is fine. And, I remember I got quite angry with the doctor, and I eventually put the phone down on him and all of that, because I was like, why are you sending me a patient, And later on, when I started learning more and started studying again, and I came across this, and I thought, oh my God, I've killed somebody, because I don't know what happened to that patient after that, whether he was discussed with somebody else, sent back to us. So, well, it's just an aside, just something just to let what, everybody makes mistakes, and if somebody's calling you from a periphery or a smaller hospital and presenting something that's abnormal to you, or something that they can't manage, or they need further investigated, even if you don't know the answer, or if you feel that they may be, should be able to handle it, but they're also not sure what to do, rather accept the patient, get somebody senior to consult, because like I say, you may find one of these weird diagnoses, even though this is not a weird diagnosis, but just something for you to think about. And of course, once your temperature reaches above 40, then you start to get CNS dysfunctions due to a systemic inflammatory response that occurs in relation to the heat. All right. So we as human beings are not designed to be in extreme heat. This is the reason why we demise in extreme heat. Okay. So what's the pathophysiology? All right. So the thermoregulation center, the hypothalamus, all right, which monitors the core temperature. So you normally have a normal response to increased body temperature, which is your thermoregulatory responses, vasodilation, sweating, and then evaporation with humidity. All right. So what happens is these fail. So you're unable to lose that heat. So you produce more heat than what you can get rid of, and you start having tissue damage. So this is direct cellular dysfunction, all right, because of what you call it, direct effects of the heat on your body. And then, of course, you have hypoperfusion, all right, because now you're having peripheral vasoconstriction, sometimes visceral vasoconstriction, but peripheral vasodilation. Okay, so what are the circumstances? So you have classical and exertional, let's just say non-exertional and exertional, all right? So these circumstances during summer heat waves without any preceding physical activity. Now, like I said, those who come from the subcontinent, Australia, Middle East, these are the things that we often read about happening to you guys in the news. I think in India last year, there were over 100 to 200 like cases a day at one point during the summer season, yeah, and a large amount of deaths, especially amongst children. And children are more prone to heat stroke simply because their thermoregulatory mechanisms are not as developed. All right, so your age generally in the children, the elderly, those who are ill, and then any medication that impairs sweating. All right. So what happens? The acid-base disturbances, they often reduced. They tend to go in respiratory alkalosis. So what happens when you go into respiratory alkalosis? Because of hyperventilation, you tend to go into that. Okay. Sweating is absent. Do they go into acute renal failure? Not really. Rhabdomyolysis, not commonly, because also there tends to be less activity involved. They don't tend to go into DIC. Okay. So in exertional, so with athletic activity, strenuous exertion, and it may be variable. You know, it may not be extremely hot, but it can be hot. Okay. Tends to occur more in adults, in young to middle age, generally healthy, like our patient, right? Patients tend to have sweating, and they tend to go into lactic acidosis. And the lactic acidosis is also because of muscle breakdown and exertion. Right? Acute renal failure, again, because of the rhabdomyolysis. Well, there you go again. And DIC also tends to occur as well. Okay, so this is an important one to know if you are working in an environment. Now, if you're working in the northern parts of Canada, it's very unlikely that you'd see this, but you may see something like this. All right. So it's not something that's going to affect. It's something that is dependent on environment. All the South Africans who are going to Australia, you should learn this. Yes. Okay. All right. So the patient, what happened after that? So the physician came in, had a look with his MO, and realized now this is exertional heat stroke, and they decided to treat the patient appropriately. So the patient was actively cooled with ice packs and chilled IV fluids, which is extremely important. So what happens now? You have a patient with you have a simple problem of thermoregulation. You are too hot. You need to be cooled down. So if you are too hot in your own room, what would you do? Remove clothing, put on an air conditioner, have something cold to drink. And this is exactly what we do as well. So there's been many times we've got patients, we just put ice packs on top of them. We give them the coldest fluid that we have available. We allow them to cool down as quickly as possible. And that's basically what helps them to recover. Now, the creatinine kinase levels are extremely elevated, 7,893, well above normal. The patient did go into acute renal had acute renal injury and was started on hemodialysis. All right. Now, in this case, luckily, the right decision was made relatively early, and the patient did survive. He was young, he was healthy as well, and like I say, the consultant was involved quite quickly. I think within 8 hours, because the patient continued to deteriorate in ICU, and because he was called, so it did make a big difference. All right. So the danger of this condition always be at the back of your mind, especially during the hottest seasons. All right. So be aware of the danger signs. If you are not sure if something is serious, rather ask and make sure. Remember to actively cool the patient with ice packs, chill fluids. a normal thing. Any patient where GCS is less than 8, intubate, monitor output with the urine catheters. Acute kidney injury does occur very rapidly, and it's due to disseminated rhabdomyolysis. Right? DIC can occur, so be careful not to put subclavian CVPs or attempt multiple IV puncture sites. What I would say is go for a femoral or internal jugular CVP if you really have to give, fluids. Alternatively, if you are able to put in a large caliber peripheral line, that actually works just as well in these patients. You don't necessarily need central access unless you're planning to measure your central venous pressure as well. So it's an interesting topic, and it's especially those of you who are working in the hotter climates, need to know about, and something that you need. It's good to go and read about it beyond what I've taught you here, but just something for you to know. This is just a little joke to finish on. So, yeah, I hope you enjoyed that. And listen, if there's any questions about the topic or anything that you'd like to know, just message me. And hopefully we can discuss it. But anyway, you guys keep well, and we'll speak again in a week's time. Bye.